Thanks for the introduction. Sir, as you said, my name is PM François, Pierre-Michel François. I'm deeply sorry to Christian names, but I didn't choose. It was too late. I'm Med LCL. What does it mean? It means that I'm a doctor and I'm a lieutenant colonel. Yeah, that's also typically military, but we don't care about that. And I'm in charge of the in CC-Med, in the Center of Competency of the Medical Department. It's a teaching center, I should say, of the responsible of the scientific board. I have to be honest with you. I'm going to talk about military doctor. Before that, I'm going to talk about what is military medicine and about my personal career, because I don't like to talk about the other, but about myself. I'm not egoistic. Don't be afraid. And of course, from dream to reality, because we don't want to make believe that it's a dream. It's sometimes a dream, but sometimes the reality is a little bit different with positive and with negative point, and I will be honest enough to tell you that. First of all, is it a dream? No, frankly. My first dream when I was a young student, it was to become a pilot, a combat pilot. I belong to the generation of Top Gun, and it was my first choice was to become pilot, not for the girl, but for the planes. And unfortunately, I had a vision problem, and that's the reason why I took my second choice, which was doctor. But I'm very happy with that, and don't be afraid about me. Disclaimer, all the views that I'm going to express are my personal point of view. Of course, they've been done in close cooperation and agreement with the staff of the medical component, of course. Who am I? But I should say I'm a good example of what a medical doctor can be and about the polyvalency and the versatility that we can have in our career. Our career can be very evolutive. When you are in the civilian sector, you start, you are graduated, you start maybe a specialization, I should say cardiologist, you will be graduated, and after that you will be a cardiologist till you are retired at 65 or 60 years, 67 years old. It is not the case in the army. You can evaluate all along your professional life. So, for example, in order to take an example, I was graduated as young doctor in '99, a very long time ago, especially when I see the young faces here. Then I was sent to Germany in order to become a general practitioner, so general medicine, in a reconnaissance armored battalion, the 3 best years of my life ever. And then the Belgian military forces came back in Belgium, and I had the opportunity to start a specialization and a residency in anesthesia and resuscitation. It took 5 years in the civilian sector, so no military life anymore, full-time civilian life. I followed that with fellowship in emergency and disaster medicine, and after that I came back to the army. But you will see that, and my colleague will explain that later, we don't work full-time in the military section. When you are in Belgium, you're working half-time in the civilian and half-time in the army. And why? Because we need to entertain and to follow the technical skills, the good medical rules that are of application in the civilian sector. If you work full-time in the army, you are losing some technical skills and some clinical experience. That's the reason why we're making what we half and half career. And so I started my career half-time in the SMUR, so the medicalized ambulance, what we call the SAMU for the French-speaking guys, and half-time in the civilian, in the emergency department. I was in the staff of the emergency department. Then a little bit later, I choose to reorient my career, and I make a fellowship of intensive care, full-time, 1 year full-time in the civilian, and I came back in the military hospital, and I was during 4 years head of department of the burn center in the military hospital, and then I choose a reorient again, and I'm in the center, the training center of the medical component, but I'm still working as a clinical anesthesiologist in the civilian sector. What about operational? Because we're going to talk about operationality, and I made some missions. I'm not talking about medical training, I'm talking about the real life, real missions, military missions, and it includes Kosovo, Afghanistan twice. First one 2004, second one 2014. I think, I got the feeling that I will not go in Afghanistan in 2024. It's going to be quite difficult. Then Lebanon, twice abroad on a frigate in Indian Ocean. Iraq, Battle of Mosul, the most beautiful experience of my life. And the last one, it was in Niger. You will see, these are some examples of pictures, but I have more beautiful big pictures to show later. There is a big problem with the army. We have a bad reputation, very bad reputation. And is it true, is it false? I should say that 90% of the rumors that you heard about army are false. But maybe 10% are true. And some people say military justice is to justice what military music is to music. And the military medicine has also bad reputation. Military medicine is like military music. When you see the bad quality of the first, you can understand. And the military doctors are considered like vampires without heart that want to cut everything and to amputate everybody and so on. This is not true. But sometimes we have to perform some technical skills that we should not do in the civilian sector, but because we need to. We are working in another setting, in a more hostile, more austere setting. And that's the reason why the medicine that we are doing during operational, it's a little bit different. We have to adapt to the circumstances. That's maybe a reason why we have sometimes bad reputation. And there are also a lot of phantasm about the combat medic and so on and all the stuff. Don't trust, don't believe them. In fact, what is military medicine? Is military medicine war medicine? Yes, sometimes it could be, but not always. Because if you take the example of people working for Médecins Sans Frontières, for Doctors Without Borders, they are also doing war medicine from time to time. We are also doing, as military doctors, from time to time, we are doing also humanitarian medicine. So it's a kind of mix between everything. And sometimes they talk about the relationship between operational military medicine and wilderness medicine. Wilderness medicine means medicine in an austere or in an hostile environment. I'm deeply sorry for the expression, in the fucking middle of nowhere. You don't have any supply, you have safety, security problem and so on, but you have to do it. You cannot say we are going to evacuate. No, it's too easy. Except in Afghanistan the last weeks, but it's another problem. So military medicine, this is the medical support to the military guys and sometimes to the civilian guys when you are making humanitarian. Military medicine, this is also occupational medicine and medical preparedness of the forces. We have occupational doctors, but it's not my cup of tea. I'm not going to talk about that. My medical medicine, my interesting medical medicine, this is curative medicine in a continuum of care. You will see later what we call the continuum of care from the point of injury to going back home and trying to have the best medical care ever possible. We also focus on the fact that we like the medevac, and we talk very frequently about medevac, medical evacuation, and from the CASEVAC, casualty evacuation, when there is a point of injury, we have to evacuate the patient, we call that the care under fire and so on, and to the STRATEVAC, strategical evacuation, when we evacuate the patient from Afghanistan, for example, back to Belgium. We like and we focus on that. So military medicine is a medicine in austere, hostile environment, and very often in a limited logistical supply. Very short history, short review of history, not of military medicine, but about the medical progress coming from the military medicine. Because I don't like war. Nobody likes war. If you like war, then you have a psychological problem. But everybody can easily understand that when there is a war, there is an increase of the technological progress in the weapons, but also, fortunately, in the medical cares. And a lot of medical progresses are coming during of just after some wars. And I'm going to give you some examples that maybe you don't know. So, for example, the first famous surgeon, Ambroise Paré, for people who you know, he was not a cardiac surgeon, he was not a big doctor, no, he was a barber surgeon. So he was able to trim the beard and the mustache and also to close the wound. That's the reason why we call that chirurgien barbier, barber surgeon. And at this time, it was only cut and close. So it was trauma care without any disinfection, without any asepsy. So you can imagine the patient could survive but died 2-3 days later from infection. But it was better than nothing. Some people survived. The first real medical organization for the medical care for wounded people, wounded soldiers, it was done by the French guys, French army during the Napoleonic Wars. And they created what we call ILF officer, officier de santé. An ILF officer, what was that? It was a doctor, but also a military, and he was officer because he was in charge of some people and in charge of the organization of the medical care and of the medical evacuation. Give some skills of manager to a doctor, it's always a challenge. I think they've succeeded, but even though you can see that it's not always evident for some doctors, but it was the first time that it was mandatory to play the role, not only doctor, but also manager, organizer. And what they did, and it was really good, they did a triage to sort the patient according to the category. They made some priority to say this patient needs to be operated and to be evacuated faster than this one. Previously, it was first in, first out. And first dead. So they made some evolution, some positive evolution in that. They also invented the first evacuation by ambulance. Of course, we are talking about horse ambulance. They also performed some battlefield care. So before to evacuate the patient, and it was amputation or tourniquet in order to stop the bleeding. This is what we actually do, in fact, in the actual military medicine. These experiences have been lost after the Napoleonic War, and that's the reason why in the 19th century, some tropical doctors, the majority, I should say, of the tropical doctors, French and British, were military, and also during the war of Crimea War, nobody knows that, everybody, there was a beautiful lady, Florence Nightingale, and people know her Miss Baby because she founded the nurses, the first nurse school. And the nurse was the missing link between the doctor and between the ambulance man. The nurse that can provide some medical care, that can provide some hygienic counseling and so on. She invented that because she saw that the British casualties during this war, they had 16,000 deaths from illnesses and only 2,600 from injury, from trauma. So, in fact, the patient has been well amputated, but without appropriate medical care, without control of infection, they died, like I told you, from illness. And as you see, all the hygienic condition, it was horrific, it was terrific. And so she emphasized of the fact that, okay, now the patient needs to be cut, need to be closed, but we need a little bit organization about hygiene and about medical care. And it's coming from the nurse. If you think that you can do everything as a doctor alone, then you are an idiot or stupid. A doctor without a nurse cannot do anything, okay? If you understand that, you're intelligent. Then Henri Dunant, the Red Cross, we will not spend a lot of time about that. Then the American Civil War. At the end of the American Civil War, people coming back from the war founded the New York ambulances, the first ambulances in the civilian sector. So when you call an ambulance now with your phone, 112, these are the descendants of the New York ambulances. World War I, a lot of medical progress, of course, improved medical evacuation chain, field hospital for early surgery, as you see, not always, what about hygiene, it's something else. First use of radiology on the field, anesthesia. You had more chance to survive after anesthesia than to die. It was done during the World War I. Blood transfusion, the first blood transfusion on the field, has been performed by a Belgian medical doctor, and improvement about trauma surgery. World War II, still better. a broad use, wide use of morphine, maybe a little bit too much. It was morphine for everybody, for everything and for everybody. If you die happy. Broad use of antibiotics. A lot of people that previously died for the wounds survive through antibiotics, and it was for the Brit guys and for the American guys, but not for the German one. Anesthesia, IV pentotal. I'm an anesthesiologist. I like it. I know that you don't care, but I like it. And a specialized unit in surgery, so more and more improvement about surgery. And all these people have been at war during 5 years, and after that they came back to the civilian sector and they used the techniques that they learned during the war. Korea War, not much interesting, but two things. Heli-Casevac, they understood that when you are on the field, when you are heavily wounded with polytraumatic patients, you need to go to the surgery as soon as possible if you want to survive. But if you are using ground ambulance, it's sometimes difficult with roads in bad state. In this case, they made a wide use of heli medevac, like this one, but you can see it's a very small heli, and the patient was along the helicopter outside. So you can imagine in winter time when it's raining and so on, it was really funny. And if the patient arrived alive, then it could be saved by the surgery. They also made for the first time hemodialysis for people who are interested by kidney diseases. There was a virus in Korea that we call the Hantan virus. Virus Hantan. It's inducing hemorrhagic fever and acute kidney injury. This is an American reservist who was working in United States. He was a researcher, and he was trying an experimental model of dialysis. When he saw a lot of soldiers suffering of that and dying of acute kidney injury, he had authorization to start his experiment, and he saved a lot of soldiers. And after that, he came back to the United States, and that's the reason why the Americans have been the pioneers in hemodialysis. Timelines, you will going to talk later. I know that you have a more beautiful slide about that. Vietnam War, the concept of first-line medical training for the combat medics. The combat medics, this is what we call in the civilian sector, the paramedics in the United States. We don't take that in France, we don't take that in Belgium, but in the United States you have people, they are not nurses, they are a kind of super ambulance men, and they are able to put IV, analgesia, intubate, exsufflate a pneumothorax. They can do a lot of things. They can do a lot of things, and we change the concept, the paradigm of the scoop and run to the stay and play. We're going to stay and play and try to stabilize the patient before to evacuate him. After that, the two last slides, it's going to be about the war on terrorism. What do we call war on terrorism? This is Operation Enduring Freedom in Afghanistan. That's just stopped some weeks ago. And Operation Iraqi Freedom. A lot of casualties, so a lot of wounded people, so a lot of medical progress. First of all, the concept of the tactical combat casualty care with some material I'm going to show you later, and the fact is that, okay, you don't need to lose too much time to make a stay and play, but you have to be very organized, very systematic. And okay, I do that. Not more, not less. I will show you. Okay, clinical protocol guidelines. A lot of practical guidelines that you are using in the civilian sector are coming from after experience of data recording from military trauma registers. Damage control resuscitation. If there is one expression, one word to remember today, it's that this is the damage control. In military medicine, on the battlefield, we do damage control. You will not make primary surgery to replace a hip joint and so on. We don't care about that. We want to stop the bleeding and to stop what we call the lethal triad. We'll show you later. And damage control hematology, I will explain that. And of course, critical care air transport team. Now we can take a patient inside of a helicopter or a plane, and we can provide the same quality of care than in a common ICU. TCC, Tactical Combat Casualty Care. Care under fire. You don't do anything. Don't lose your time. Care under fire, it means that it can be dangerous for yourself. Don't lose your time. Stop the bleeding, that's all. Try to survive before to give medical care to the patient. After that, tactical field care. If you're interested by the challenge, you will have the occasion to perform tactical field care. We use the MARCH protocol, massive bleeding control, airway respiration, circulation, hypothermia. It's a little bit like the ABCD that you are using in the civilian, but it's more systematic. You do it, you don't do it, but you don't lose any time for further diagnosis and so on. You do the skills that are needed to make survive the patient, and you don't lose any time. And after that, tactical evacuation care. Combat application tourniquet. You're going to tell me this is something that you use to stop the bleeding. You're going to tell me, oh, you don't use that in the civilian sector. No, this is not true. It was used during the attacks in the Malbec and I don't remember the name of our national Luchthaven. National Zaventem, I'm deeply sorry, I'm Belgian, but sometimes I don't remember, of Zaventem, they used not by the medics, but by the soldiers that were there. They jumped on the patient in order to stop the bleeding with the combat application tourniquet, and they saved lives. So it can save lives in the military setting, in the civilian setting. All the practice guidelines that you are using, the ATLS, the European Trauma Course, and so on, the majority of them are coming from experience from the trauma registers, American trauma registers. Damage control resuscitation, fight against lethal triad, hypothermia, acidosis, coagulopathy. You are outside, you are losing temperature, you are losing a lot of blood, you are losing a lot of fluid. It induces a metabolic acidosis and so on. And as you see, it's a circle. And it's getting worse and worse. In this case, what are we doing? Damage control gone zero. This is the MARCH resuscitation or the ABCDE that you know in the civilian. Then damage control hematology, permissive hypotension, limitation, crystalloid, early use of blood and blood products. You're going to tell me, but we are doing that now in the civilian. Yes, but 20 years ago, you didn't do that. You do that because we did it 15 years ago. And then, of course, the damage control surgery for definitively stop the bleeding. Before, it was separate steps. Now, it's a continuum of steps. We are doing the resuscitation during the surgery. We don't have to wait to start the surgery, but we don't have to wait the surgery to start the resuscitation. It's all together. The massive transfusion protocol, I told you, the Copenhagen concept, we give fresh frozen plasma, we give blood, and we give platelets, but yeah, it's coming from return of experience of Iraq and Afghanistan. And so, in fact, what is the relationship between military medicine and civilian medicine? In fact, as I told you, the war induces technical progress, okay? Technical progress, it means that we will have a lot of civilian research, industrial production, with a lot of military money, because we need this progress. And this relationship is quite good and quite positive, because we will have cooperation, civilian military cooperation, between researcher, technician, manager, and people that are very important, reservists. Reservists, these are civilian guys going to the military reserve, and from time to time, they will go on the field, but they come with civilian eyes, with up-to-date IDs, maybe with fresh IDs. And so they can make the military world evaluate. And the big advantage in the army is that when we decide to implement a new protocol, a new clinical guidelines, it's going to be a big-scale implementation. When the Americans said in the American army, okay, from tomorrow we will do T3C, everybody will do it. In the civilian sector, some doctors will say, okay, I will wait a little bit. Other doctors will say, oh no, I don't like my colleague, I will not do this technique and so on. No, in the military, when we say you do like that, we do like that. And so it was easier to have the big scale implementation in a military setting. And so we can make clinical studies to see, is it working, is it not working? And so the combat-proven medicine can become later evidence-based medicine that can be used in the military, in the medical literature like PubMed and so on. So now that you know, that you have a small idea of what military medicine is, I'm going to talk about military doctor and about my own experience, because I told you I'm not egoistic, but I like to talk about myself and not about the others. And in the civilian, I'm anesthesiologist. Anesthesiology, what does it mean? Specialist. This is not only put in sleep. No, this is perioperative physician, control vital parameters, perioperative care, postoperative care, and in fact, we are working in the operating room, but also in the emergency department, in the shock room, and also in the ICU, in the intensive care unit. Okay. So this is what we do in the civilian. What do we have to do in the army? So a military anesthesiologist, it's like in the civilian, but it's a little bit much more because we need to be more versatile, more polyvalent. Do we need to be muscleman or G.I. Joe anesthesiologist like these guys? Well, have a look at me. No, I don't look like that. What do I need? I need to be fit enough to be able to run, to carry my backpack if needed, and to shoot a gun. That's all. They don't ask me to be a muscleman. If you take so much time to become a muscleman, then you have a lot of muscle, but you have very few in your brain because you are losing your time. You don't have any time to do anything else. Okay, but military anesthesiology needs to be able to work in a austere environment. We are back to the wilderness medicine. With safety or security issues, that's the reason why we must be able to protect ourselves and the others if needed, with limited medical supply and a very small logistic footprints. And from time to time, we have the right to do humanitarian medicine, if accorded. What is a military anesthesiologist? In fact, it's a medical doctor, 6 years, then 5 years of residency in the civilian sector. But my colleague will explain you later that more in details. And then we asked to do a fellowship in intensive care or in emergency in order to be the most polyvalent possible. Does work? Okay, we will see that later. Okay, what are we doing when there are no operations? Because we are not always on the field, fortunately. From time to time, we are in Belgium. We are working half-time in the civilian sector and half-time in the military sector. As anesthesiologists, and I should say all the critical care doctors, we are working in the burn center. We are working in the burn center. We have high care, so ICU, intensive care, medium care, and so on, operating room. And so we can make the full spectrum of peri-operative care, child, pediatric, adult, and so on. But this is quite limited because we don't see polytraumatic patients, we don't see cardiac patients. So we don't have enough technical skills. That's the reason why we need to work half-time in the civilian sector. When we go in operation, and I took my personal operations, the first one it was in Lebanon as anesthesiologist, and it was a typical example of small military hospital, what we call a World 2. And this World 2, we had a shock room, we had 2 operating rooms, 2 ICU beds, not much, you're going to tell me, but it's very small, only 12 beds for the ward. Yes, it's very small because the patients are not supposed to stay longer in the hospital. We stabilize the patient, we operate the patient, or we perform resuscitation, and once the patient is stabilized, he must be evacuated through the medical chain to another, better equipped hospital. So you will never stay during weeks in this hospital. You will stay some hours or maybe some days, but not weeks, like in a civilian setting. In Lebanon, you're going to tell me, yes, but it was everything is khaki, everything is green, so it was only for the military people. No, this is not true. If you look to the consultation of the World 2, the hospital, we made Belleville, it was the Belgian, Luxembourg forces and so on, and this is the civilian. You see 10 more of civilian consultation than military consultation. Damage control surgery is absolutely the same. In Lebanon, we made more humanitarian medicine than military war medicine. But sometimes we are in another setting, we will do more war medicine. I will show you later. And of course, in Lebanon, it was really good because as anesthesiologists, we made the full spectrum of peri-operative care, pre-hospital care, triage, operating room, ICU, ward. We can play a polyvalent role in all the different modules. It was really, really interesting. We also sent a lot of medical doctors and nurses, and I went to Kandahar, so in Afghanistan, 2014. It was in a multinational hospital. The definition of multinational means American hospital, okay? The multinational, it was 99% of American guys, but they call that multinational. And it was a multinational World 3, so a well-equipped hospital with concrete walls, with a CT scan, with neurosurgery, and so on. So like in the civilian, very well equipped, and there we play the role only in the trauma bay, in the shock room, for the airway. In the operating room, it was only anesthesia, and ICU only if you have the qualification, the fellowship in intensive care. That's the reason why we ask to do it. And this kind of patient, you're going to tell me, okay, you see that every 2 weeks. No, this is not true. This kind of patient, we saw several of these patients every day, between 2 to 10. So we had a lot of job in Kandahar. As you see, maybe with the sun and with the light it's a little bit difficult, but as you see, this patient has 2 tourniquets, combat arterial tourniquet to stop the bleeding. I already show you. You can consider that this patient, without stopping the hemorrhage with the tourniquet, this patient should not arrive alive in the hospital because he's going to lose all his blood. He should be dead, in fact. So that's really useful. Classical lesions coming from ID, from mines, and so on. Multiple amputation for young people, so very difficult to see that because these people, they had between 18 to 25 years old. So it's quite typical lesion. Also, you see you saw the 3D CT of a typical lesion of a gunshot wound through the head, and you see the small hole of a bullet, the in, and through the cavitation there is the out, and between the two, of course, there was a huge cavitation. You can imagine all the internal lesions. Last, most beautiful experience, it was a SOS team in Iraq during the Battle of Mosul, special operation surgical team. So very limited team, 6 people, 1 liaison officer, 3 people for the surgery, 2 people for anesthesiology and ICU. This is the operating room. This is the material for operating room, and we have to go under a tent or under a building. This is my civilian hospital where I'm working. A classical operating room with all the stuff that I use every day. It's beautiful, a lot of technology. We don't have that. When you have to work in a rotten building, or when you have to work under a tent, that was my monitoring. That was all I had to stabilize the patient and to save the patient. And it worked. It worked quite frequently. You see the typical civilian organization, that's beautiful, that's clean, and so on. It was my anesthesia table with dirty walls and so on in Iraq. It was dirty, but it worked. What we did there in Iraq, it was very limited, very not far from the battle, from the line of battle and the front line. In this case, the surgeon plays a role of damage control, surgery, anesthesiologist, damage control, resuscitation, reanimation, specialist, and we are not doing it separate, but in the same time, always the fight against the lethal triad. Some examples, the same than in Afghanistan, multiple amputations, fascial trauma, and so on. Clamshell thoracotomy. I saw more clamshell thoracotomy there in Iraq than I saw in Belgium. When you do a clamshell thoracotomy, 90% of, not of success rate, but failure rate, of course, unfortunately. So, personal conclusion. Anesthesiologist is a perioperative physician but can be much more polyvalent. We are pragmatic, boots on the ground. I hope that you understand that. A good military anesthetist must be a good civilian anesthesiologist. If you are a full-time military anesthesiologist, you are a bullshit anesthesiologist. We need the technical expertise and the technical skills coming from the civilian sector. We must be polyvalent. If you are not polyvalent, if you are over-specialized in pediatric anesthesiology, in cardiac anesthesiology, then you are not a good anesthesiologist in the army. You need to be as polyvalent as possible. And I can be your best friend if I want. So, take-home message as military doctor. Polyvalency, versatility is required and even essential. You need some leadership and communication skills, maybe a little bit than in the civilian sector. You need to love to travel, as you easily can understand, and to be flexible. And also from a personal point of view, it's not always easy. You must be aware of that. But you will have the possibility of evolutive career development. I mean, I explained to you, okay, you can start as GP, then make the specialization, then to make, if you please, you can make more human resource management as a pharmacist, for example, or like me, in order to give some training now. So the evolution of our career is maybe more polyvalent than in the civilian sector. And what do we need? We need mostly, but she's going to explain that, but we need critical care medicine specialists, mostly. And in fact, acutist, anesthesiologist, trauma surgeon, and so on. We need, in fact, damage control doctors. So I thank you for your attention, and I'm going to give you the floor to my colleague. Thank you.
So I hope some of you might be interested in becoming a military doctor, because I'm going to talk about the recruitment and selection and about the specific military program for a military doctor. So I'm Riet Monserez. I'm a hospital pharmacist. I joined the army in 2004, and the first 12 years of my career I worked in a military hospital in the pharmacy. But then after doing a course of 1 year in the Royal Military Academy, I am working at the staff for this moment, and I'm working on recruitment and selection. So this is the agenda of my presentation. I will start with a small introduction. So why does the Belgian Defence need doctors? So the core business is missions abroad. So Dr. François already showed you nice pictures of that. But we, as a medical component, we have to provide medical support to the operations executed by the other components. So land, navy, and air, of course. So when they want to do a mission, we, the medical component, we make a plan, a medical support plan, and we decide who we want to send into that operation, what is needed. So as medical personnel and as medical treatment facility and material. So here you see, we need doctors. We need doctors into the operation, so into theater, but we also need doctors here in Belgium to prepare the troops to leave. So to see if everybody who will participate in a mission is physically fit and in a good shape to avoid many problems in theater. So this is a picture just to give you an idea of how it looks like in a mission abroad. So in the role 1, you have the injury. That's the point of injury. Then the patient has to be in 10 minutes in a role 1, and that's where he first sees a doctor. So there is a doctor. Normally it's an emergency doctor or a general practitioner in some cases. Then the patient has to go as fast as possible after stabilizing into a role 2 basic or a role 2 enhanced. So the role 2 basic is a really small field hospital where they do damage control surgery, and the role 2 enhanced, you saw it also on a picture of Lebanon, is a well-equipped hospital. And then you have a role 3 who's not on a picture, and then you have the hospital on national territory. So this is the chain with the evacuations. We call it the continuum of care, really important. So this is to give you an idea of the medical technical corps. We call it that way. The medical technical corps consists of doctors, dentists, pharmacists, and veterinarians. So you see that the numbers are rather limited. So we're in real need of doctors and dentists. If you see surgeons and anesthesiologists, 5, that's not a lot, because they leave for 1 to 2 months maximum when they go on a mission abroad. So we already need 6 to full a whole year. But the good news, you see on the right, we have doctors in training, 77, though that's a lot. It's better every year. So every year we have more or less 5 or 6 doctors that are graduating. But dentists, it's still a problem. It's really difficult to recruit them. So something more about the different types of recruitment. So we recruit people at the age of 18, so to start the study of medicine. That's called normal recruitment. Then we also recruit after first or second bachelor. It's complementary recruitment. For us, these candidates are more interesting because they already showed that they have passed first and or second bachelor. Then we have the special recruitment. That's after the 3rd master you can join the army, but that's only to start the specialization of emergency medicine. That's the only possibility. If you want to join the army later during your specialization, you can do it when you're doing anesthesiology or surgery or some other specializations. It depends on what we need at that moment. So these 3 types of recruitment are for doctors and dentists, because we try really every way to recruit them. Veterinarians and pharmacists, we don't have any problem to recruit them. We have enough, so it's only after they're graduating that we recruit them, so the special recruitment. So the age limits are 34 for the 3 first types, and then you also have lateral recruitment. The age limit is 50. That's for doctors or dentists with an experience of at least 5 years, professional experience. So finally, during your whole life, you can join the army if you want. These are the tests that you have to pass when you want to join the Belgian Defence. So you have to pass a medical examination, some psychotechnical tests, a sports test, and a language exam. We see that for doctors, the language is the most difficult. So these first 4 tests are for all candidate officers, and then more specific for the medical technical officers, there are 2 more tests to pass. It's an interview, a motivation interview, that's done by a military doctor, and you have to pass the entrance exam at university. So that's for those who want to join the army at the age of 18. For us, that's the most important, that people really know what they are going to do, what they can expect, so with a good motivation. Something more about the education. So there are 4 important pillars. You have the military pillar, the academic education, the physical pillar, and language. So about the military training, I will not go into much details, but at the beginning you have military basic training. It's 6 weeks for doctors, and then another 4 weeks, and that's during the summer holidays. And after you graduated, there is still a specialized professional training, and that's in the Center of Competence in Neder-Overheembeek, where Dr. François is working at this moment. Here are some pictures. Then we have the academic part. So as you know, the Master in Medicine is 6 years. There is a free choice of university, so our military students are all over Belgium. We think it's interesting because every university has its own approach, so it's interesting to have them everywhere. And they depend of the Royal Military Academy, more specifically the special division is DIF. So after the 6 years, you have to do a specialization. There are not that many possibilities in the army, so we don't need gynecologists or pediatricians. It's not necessary. What we most need is general practitioners, emergency doctors, surgeons, anesthesiologists. And from time to time, every 3 to 5 years, we open a place for an ophthalmologist, infectiologist, and so on, to work in the military hospital. So for these specializations, we work together with certain universities, for example, for emergency medicine, but that's only the 3 years. So it's acute ou médecine aiguë en français. Donc it's 3 years and not 6 years. It's a big discussion, so maybe it will change, but at this moment, it's still what we offer. And so for that specialization, we work together with Antwerp and the UCL. So what we do is we make a training concept in which we write down what competences our military doctors have to learn, what courses they have to follow, what specific skills they have to develop, and the university decides if they can offer that or not, and then we start a collaboration. What's also interesting to know is that you have to do 1 year in the second language, because as I said, languages are important for an officer in the army. And you also have to follow 6 months in English. And then more specific, the possibilities in case of special recruitment. So if you want to join the army after your 3rd master, you can start emergency medicine, so 3 years. It's 12 months in UCL, 18 months in Antwerp, and 6 months in Birmingham. We are looking for other collaborations in English, maybe, but for now it's Birmingham. And as I said before, you can join defense after the 1st year of anesthesiology or surgery or other. We also need psychiatrists, but I don't know if that might interest you. So the 3rd pillar is the physical pillar. It's your own responsibility. You have to train, you have to stay in shape, you have to pass an annual test. It's not that difficult, it's just side bridge. And 2.4 kilometers of running, so it's not far, but it's rather fast that you have to run. And then the language, I have to say that defense prepares you really good to pass the tests that you have to pass from time to time. You have a 3 weeks course, but then you have a lot of additional courses that you can follow. This is an overview of the education of the program. So in light blue, you see the academic part, which is of course the biggest. Then you have the military training. It's in dark green. So it's in during summer holidays. So in the 1st year and the 2nd year, you have the basic training. Then in light green, you have the weekends is diff. So weekends organized especially for the special division for the doctors in training. There you learn to develop your military skills. It's 3 times a year. Then you still have in purple the language course. And then in yellow, it's what we organize at the staff. There are some moments where we invite every military doctor in training because we want them to know each other. They have to be one group. And as they are studying in universities in Belgium, we don't see them a lot. So it's really important to organize this type of activities. So now in September, it's next week, we have the 3 days. We call it the 3 days. And then we offer a program where they learn to know more about the organization that defense is. And in July, you have the summer camp, medical summer camp. That's where we try to teach them the things they don't learn at university. So there is a big difference, as Col François showed you, a big difference between a civilian doctor and the military doctor. So we learn them a bit how to work as military doctor during that camp. And in pink, you still have the internship in the military hospital. So there's not many time left, but yeah, I can be really short about this. So the career of a military doctor consists of 3 parts. It's on the national territory. So for a primary care physician, it's half the time. You're working in a regional medical center and you prepare the troops, you give trainings and courses, you give medical support to exercises and trainings of the other components. Operations, that's abroad, 2 months a year maximum, normally. The most important is to keep the patient alive. But most of the time it's primary healthcare. 90% it's primary healthcare, 10% it's emergency medicine for a primary care physician. And then you have some, that was shown already. You work here in the role 1. And then you have some complementary training activities. It's in Belgium in an emergency service with a general practitioner. And that's 60 days a year that you can work somewhere else. And of course you have an extra salary, which is interesting. For a specialized care physician, it's more or less the same. The difference is that in Belgium he works in a military hospital, not in a regional medical center. It's also half the time, and also he gives courses and training. Operations, that was shown by Dr. François. So you work in the role 2, basic or enhanced. And the complementary training activities are also in Belgium in a civilian hospital. And the goal is to keep the competences up to date. And for a surgeon or anesthesiologist, it's about 80 to 100 days a year. So that concludes my presentation. If you have any questions, don't hesitate to ask them, or to ask the people who are here in this clothes. So I really hope that someone might be interested to joining us. Thank you.